One of the other areas, when I started my career as a cardiologist, I graduated fellowship, and so I had done some research in the field of anticoagulation, and I really consider myself a preventative cardiologist. And so I had done some research in the area of anticoagulation, or blood thinners, so they're called. And my first job, actually, as a new staff, was my boss kind of patted me on the back and said, "Guess what? You're the new anticoagulation clinic director at Walter Reed." And I did that job for over 4 years. And so I became very interested in the field of preventing stroke. I think what we learned was that back in the day, so to speak, back when I was an anticoagulation clinic director, all we had was Warfarin, or what's known as Coumadin. And it was either that or use drugs like aspirin, which are aspirin's very effective in the treatment and prevention of coronary heart disease, but is not nearly as effective at treating atrial fibrillation, stroke prevention, or blood clots and things like that. That was really a real limitation, and of course, at the time, having only Warfarin, it required, the issues that we know that are true with Warfarin. It required a lot of very close monitoring. There's a lot of drug and food interactions. We, had a lot of people involved in that, called an anticoagulation clinic. One of the areas that I've been really interested in is since 2010, we have seen the introduction of several new anticoagulants. And these are called novel anticoagulants. Some people call them, now they're not so novel anymore. They've been around now for almost 6 years. Some people call them non-vitamin K anticoagulants, or NOACs. But whatever you call them, I think when you look at the literature as a group, this has really been a step forward. And so as a former anticoagulation clinic director, I was very excited about this because I had grown up in the Coumadin era, and we undertreated a lot of patients. We had a lot of patients who were having strokes because they weren't on treatment because of the problems they had had with Warfarin, or just the fears that they had with Warfarin. And so what we've realized over the last 6 years is that the newer agents appear to be at least as effective, and probably in many patients more effective at reducing stroke. They're obviously easier to use because they don't require the monitoring. But they have vastly fewer drug and food interactions. And so this has been a real breakthrough in, I think, my career. One of the things that we've seen at this meeting is that the newer drugs have been criticized over the last few years as not having what we call a reversal agent. And so that even though they appear to be at least as safe as Warfarin, if you had a patient who was bleeding, then you kind of just had to stop the drug and treat them conservatively. You didn't have that specific way to turn the drug off. So what we've seen at this meeting and over the last year is we're starting to see the introduction of reversal agents that are specific for these novel drugs. And I think that is truly, and they seem to be very rapid onset. They seem to be very safe. And so that's been exciting for our patients to now have options. So now that when they come in to see us in clinic, it's not just Warfarin or nothing, right? And now they have Warfarin still, which has been around for over almost 6 decades, but they've got 4 drugs that are novel anticoagulants that are each slightly different, but that we can help them choose one of those as an option as well. And so we're now I think it's an exciting world to be in the anticoagulation. AFib, quite frankly, is just so prevalent. I mean, it's really a very common problem. It's one of the leading causes of stroke in the United States, and in fact, the stroke, of course, is the 5th leading cause of death, and the strokes from AFib are largely preventable. I think the first thing we do is, I think you have to realize that with any new therapy, it should be used in accordance with the package insert, and it should be used as studied. So, for example, Warfarin is still a very good choice for some patients, and it should be the only choice for those that have mechanical heart valves, for example. These drugs have not been studied in those patients. There are lots of other indications, quite frankly, where we use Warfarin, and these drugs have not been studied. And so you want to make sure that you're using it appropriately. That's the first step. And the other example would be in patients who have advanced kidney disease. I mean, all of these new drugs, to some degree, are cleared by the kidneys. And so in our patients, for example, that are on dialysis, they should be on Warfarin. And so that's really kind of the first start is this person sitting in front of me even eligible for a new drug? And if they're not, then they don't have those choices. But I would like them on warfarin as opposed to aspirin or nothing. If it's a candidate for a novel drug, I think we look at a lot of factors. I think we look at their kidney function, their age, and you try to pick a drug that works for them. And there's a lot of different factors without getting into specifics about the individual agents. But we're very fortunate that we have all of the novel drugs at my institution available, which gives us some options. My own personal bias is that we try to find the right drug for the right patient. And so we don't just say, well, we only use this one drug or this other drug. And I think there are some differences individually that do lead to that. I think the key is just getting them on therapy and making sure that whatever therapy is chosen, whether it's warfarin or whether it's a novel drug, that they are compliant with that therapy and they understand why they're on it. Because as you know, there's a lot out there on television, ads saying, these drugs, maybe not as safe as we thought. That's where the excitement about the reversal agent comes in, because even though we knew the bleeding rates were low, they still, life happens. And people need to go to surgeries urgently. They fall and break a hip and they have to go to the operating room. We'd like to be able to reverse it. And so the reversal agents are really exciting for that reason.